Good morning, everyone. This is Dr. Cindy Herndon. I'm going to be recording a presentation on the nurse's role in family planning, Chapter 31. And in this chapter, it talks about the nurse's role in interacting with couples, with women for family planning. And the nurse's role generally includes answering general questions concerning contraceptive methods. The nurse must be comfortable talking about these things, and she also must be knowledgeable about all of the methods of contraception, explaining different methods available, as well as the advantages of each and the disadvantages of each. And then also, once a contraceptive method has been chosen by the woman and by the couple, teaching the correct use of the contraceptive method is important. Also, the side effects, benefits, availability, expenses, making sure the woman knows what signs and symptoms to look for reporting to the practitioner, to the provider, in case there are any signs that are very, very concerning. And also, just the regular general side effects that would not be concerning necessarily, but just something that they should know. The benefits, the availability, and then the expense. And in public health nursing, of course, a lot of times they are available without cost to certain populations. So that's something that you might be aware of. And then as nurses, we are the counselor and the educator. If you ever hope to progress in your education to become a nurse practitioner, then that role would be expanded and you would be the provider. So you need to know even more and be available to educate and to offer counseling for them. And I would like for you to consider what questions a woman might ask regarding her contraceptive methods. And there is information in your text on page 664 and 665, and we'll be doing an activity in class regarding this, so you can jump ahead and look that over. And also, I would like for you to consider examples of proper and improper education regarding contraceptive methods. Your objectives for this presentation include identifying assessment data for family planning and contraceptive teaching, describing health promotion and maintenance activities for issues related to sexuality across the lifespan, employ the interdisciplinary team for the management of sexuality issues, apply pharmacological interventions in caring for the patient with sexual needs, develop a plan of care to meet the sexual needs of the patient, describe the role of the nurse in helping in the selection of a method of contraception, describing the important considerations when choosing a contraceptive method, explain why informed consent is important for contraception, and compare and contrast contraceptive needs of adolescent and perimenopausal women. Also, to explain the mechanism of action, advantages, disadvantages, side effects, and teaching needed for methods of family planning, discuss the nurse's role in contraceptive counseling and education, and explain factors that can impair a couple's ability to succeed. Objectives continued are describe factors that can cause repeated pregnancy losses, specify evaluations performed for infertility, explain the use of procedures and treatments that may aid a couple's ability to conceive and carry the fetus to viability, discuss the nurse's role for families needing care related to fertility or infertility. And there's a lot of information about this in your text. It's very interesting, and you should be very familiar with it, so you'll be able to perform these nursing roles. There are many considerations when counseling a woman on the method of contraception she chooses. So she needs to be informed of many different choices before she makes that decision. And some of the considerations in making the decision are safety. Safety is a big consideration for a woman, especially if she has hypertension or if she smokes. And so any type of hormone contraception should be contraindicated for those women who smoke and who have hypertension. Condoms offer protection against STDs and will not interfere with her treatment for hypertension if the woman is hypertensive. Condoms will not increase her risk for pelvic inflammatory disease, such as will the IUDs, especially if she has more than one sexual partner. All hormone-related contraceptions are contraindicated in those women with hypertension and who smoke. Hormone-related contraceptives also do not offer protection against sexually transmitted diseases. The effectiveness is also a consideration. Copper IUDs have an effectiveness rate of 99.2%, and if the woman is monogamous, she has one sexual partner, then that is a good choice for her because she will not have the chance of contracting sexually transmitted diseases, and that is including her partner. He has to be monogamous as well. He has to have only one sexual partner so as not to bring back a sexually transmitted disease to her and cause a pelvic inflammatory disease with the IUD. Condoms are 86% effective if they're used correctly, and diaphragms are 80% effective, and then the cervical cap is 60% effective. Oral contraceptives, if used correctly, have a 91 to 99% effective rate. And then acceptability. Some women perceive spermicide and condoms as messy, so they will not accept that method, and they say that it has an impact on the spontaneity of the sexual contact, so they will not accept that form of contraception. Convenience is also a consideration, and depending on whether or not the woman can remember to take the pills are very convenient. But if they continuously miss pills, and then it becomes inconvenient for them. And then just not having to stop and use a contraception during the time that they are having their encounter is a consideration. IUD, if they are monogamous, again, if they only have one sex partner and the sex partner has one sex partner, which would be them, then they could that would be convenient. Education is needed in any contraceptive use. They have to be educated as to how to use those, especially if they are teenagers. They need to learn how to use these to prevent a pregnancy. Some contraceptives have have benefits that are unintended, such as oral contraceptive or any hormone contraceptive. Sometimes they clear acne. Sometimes they cause the periods not to be so heavy. They allow women to have light periods, and they correct irregularity of periods in some women. Natural family planning often offers freedom from exposure to hormones, and condoms provide better protection against HIV and other sexually transmitted diseases. Okay, effect on spontaneity. We talked about that a little bit. It must be readily available when she needs it. And if she's taking oral contraception or has an IUD, that does not interrupt, and it allows for spontaneity. Expense is a consideration when you consider per use. Every time that is used, it adds up. And then compared to IUDs, which can be left in for 5 to 10 years, that's a big difference. I want to remind you that the Public Health Department does provide free contraception to some populations, some subgroups of populations. So that's a consideration as well, and it is confidential, and teenagers do not need parental permission or parental consent for that. And then just personal preference, religious and personal beliefs. Some women have values, they have different values. They believe that family is important. They like to have large families in some cultures. Especially they like they need to have sons in some cultures. So that is a consideration. Other considerations include avoiding harmful effects to their breast milk if they're breastfeeding. So that's a very big consideration. And informed consent has to be received, has to be completed for some forms of contraception that would prove harmful, such as if she is hypertensive and wants a contraception that would have harmful effects for her in that way. Consent is needed for implants, for IUDs. Some of the IUDs release hormones, and so that would be the woman would need to have informed consent on that. And then injections, they have sometimes side effects. They are given every 12 weeks. They are good for every 14 weeks, but they do cause headaches. They do cause delayed ability to conceive after they are no longer being given for a certain time, and it varies with women. With different women, it varies. Of course, sterilization has to have a consent because that is usually irreversible, and sometimes it can be reversible, but it's very costly and it's not guaranteed. Emergency contraception is a form in different forms. They have different forms of that. It's a pill that can be taken anywhere from 72 hours after the sexual encounter to 5 days afterwards, and it can it's not 100% effective in all cases, but one form, the olapresol acetate, or ELA, acts to delay or block the luteinizing effect in the ovulation. It also inhibits implantation, and the pregnancy should be excluded because it can interfere with an existing pregnancy. So sometimes this is considered like an abortion. They think of it as having had an abortion. So that is an important consideration if they have those thoughts in relation to religious and personal beliefs and cultural beliefs. Adolescence and contraception. Adolescents, they sometimes get their information from their friends, and sometimes that information is misinformation, and they do partake in risk-taking behavior. Sometimes they believe that in their groups of friends, they believe that they can't get pregnant the first time. They believe that they can't contract a sexually transmitted disease. They pretty much consider themselves sometimes invincible because that's just the nature of adolescence. And so we need to really pay great attention to these as nurses, to this group as nurses, and counsel them thoroughly. They listen to people who take time to be sensitive toward their feelings and their concerns and their needs. And so if we respect them, if we treat them with respect, then and we convey to them that everything that they talk to us about is confidential regarding their sexual activity, then they usually really respond well to nurses. They do trust nurses usually, and 39% to 50% to 50% of teenagers report not using condoms. So we really have to do some education with condom use, with condom proper use with the adolescents. And some believe, of course, as I said, some believe they can't get pregnant on the first time. Some even can get pregnant before they have a period if they're ovulating. If their ovaries are functioning and they're functioning for the first time before that period comes, they can actually conceive if they are sexually active. So that is something that we need to reinforce in our counseling. If they're not having normal periods, they could still become pregnant. So again, use respectful counseling with them, treat them with respect, use understandable technology, and just maintain, reinforce the idea that that we are a safe place. We're a safe profession. They can talk with us, and the confidentiality is protected, so that and they can get contraceptives without parental consent. So all of that needs to be conveyed to them, and building a rapport with the teenagers, building a trust with them is very, very important. With perimenopausal women, they may continue to ovulate as long as they have menstrual periods. Fertility begins to decline when women reach 35 to 40 years, but they are still at risk for becoming pregnant, so they do still need a contraceptive method if they do not desire to be pregnant. Pregnancy after 50 is uncommon, and menopause usually occurs. And menopause is defined as not having a period for 12 months. And that usually occurs between the ages of 52 to 54 with most women. Not every woman, though. Women over 35 with cardiac risk factors should not use combined hormonal contraceptives and should not be a smoker. If they have hypertension, they should not use a combined method of hormonal contraceptions at all, as I said earlier. The most common method used by women older than 30 is sterilization and progestin-only hormonal contraception. The method for sterilization, the female sterilization is called a tubal ligation or a bilateral tubal ligation, and this is when the fallopian tubes are cut or they are occluded to prevent fertilization. Some of the ways that physicians do this at surgeries happen are placing clips or bands or rings and removing a part of the tube. And they sometimes tie the tube or they cauterize the tube. So this is most often irreversible. Sometimes it can be reversible, but it is very hard and it's not guaranteed. So the woman really needs to know for sure that this is what she wants. There is a risk of ectopic pregnancy after the tubal ligation. With that small percentage of risk for pregnancy that could occur, most of the time if it occurs, it's going to be a tubal pregnancy or ectopic pregnancy. General anesthesia is most commonly used, but regional anesthesia can be used. And so the optimal time, the most opportune time for this to occur is after a C-section or 48 hours after a vaginal birth, because at 48 hours after the vaginal birth, the uterus has moved down so that the physician, the surgeon, can access the fallopian tubes. For male sterilization, this is called a vasectomy, and during this procedure, the vas deferens is cut, and in order to do that, there is an incision in the scrotum that is made, the couple must use an alternative method for 20 ejaculations or 3 months time, because there still may be sperm that is left in the male anatomy that may encounter the ovum. So a test for sperm count is completed for 2 specimens after that 3-month period. It is highly unlikely to become pregnant after this procedure, and it is recommended that the couple be counseled that sterilization offers no protection against sexually transmitted diseases. But the sexual function of the male is not impaired after this procedure. And the man does wear scrotal support for 2 days, and ice is applied for 4 hours after the surgery. And he avoids activity for 1 week. And this is usually done in the doctor's office, and it does not have to be done in a hospital. It's very convenient. And it is safe, it's easier, less expensive than a bilateral tubal ligation for the woman, and it has a lower failure rate than tubal sterilizations. So this is a very popular procedure for couples. And again, it can be performed in a physician's office under local anesthesia, and again, it is less expensive. And sperm, I can't emphasize this enough, sperm may be present in the ductal system distal to the ligation of the vas deferens when the surgery is performed. So the couple should understand that the man may be able to impregnate the woman until sperm are no longer present in the semen, which could occur up to 3 months after the procedure. So the man should submit semen specimens for analysis until 2 specimens show that there are no sperm in the semen present. The IUDs are permanently inserted. One, the copper paraguard is inserted and can be left for 10 years. And then the marina or Levin marina can be kept in place for 5 years. The action of the IUD is that progestin is released, thickening the cervical mucus, and it does prevent sperm from moving up into the uterus and past the cervix. So the side effects can be cramping, increased bleeding during menstruation, and may be followed by amenorrhea. And some teaching points are that some of these have cause a woman to be at higher risk for pelvic inflammatory disease if they have more than one partner and they're practicing multiple partners. It is inserted into the uterus, and fertility does return when removed. It is considered safe for adolescents and for women who have never had a baby. And there is a slight risk for infection for the first 20 days because of just the implantation of this. There's not an increased risk for pelvic inflammatory disease if condoms are used. And then there's the issue with the string. The woman needs to check for the string once a week during the first 4 weeks, and then after that monthly, after their periods, to make certain that the string is still in place so that the practitioner can remove the IUD when it is time to be removed. Also, there's teaching that needs to happen with the woman. She needs to report any fever that she has, any pain, any itching, and any discharge. With hormonal contraception, this is a form of temporary birth control. Some of the types of hormonal contraception include the hormone implant. There's hormone injections, such as Depo-Provera, that are injected every 14 weeks, and they need to be scheduled every 12 weeks so that there's not an interruption of the hormone that works within the woman. Of course, they do have side effects of headaches and weight gain and bone loss, and they are not recommended to be used more than 3 years most of the time. So then you have oral contraceptives, and those come in many forms. There are combined oral contraceptives, there are progestin only, and then you have emergency contraceptives, which are also a hormonal contraceptive. There are at least 2 types of those. And then the transdermal contraceptive patch, which can be used easily. And you have the contraceptive vaginal ring, which is used for 3 weeks and then out for 1 week. Or the woman could use it continuously and not have a period, which can be prescribed. And with the hormonal contraception, it prevents ovulation, makes the cervical mucus thick and resistant to sperm penetration, and does not protect either partner from a sexually transmitted infection, including HIV. With this, we're going to do a class activity in which you will flip the classroom, and you will divide up in groups and research different different contraceptions, period, and then report back to the class. There are hormone implants. Next, Planon, upper arm, into the upper arm. This type of hormone contraception releases progestin, and it is used for 3 years. It is kept in place for 3 years. It works to thicken the mucus, to inhibit ovulation, and the side effects include, some of the side effects are that the woman may have irregular periods. This method is safe during lactation. It is reversible, and fertility returns in a few weeks normally. And then you have the hormone injection, Depo-Provera. It is given intramuscularly or subcutaneously. It includes no estrogen. It prevents ovulation for 14 weeks, but it should be scheduled every 12 weeks. After the injection, the nurse should not massage the site because that would increase the absorption, and this is meant to be absorbed slowly for 14 weeks. The women do report abnormal menses. They can lose bone density, which is a concern. So the recommended time for use is only 2 years. And there is a delay in return of fertility once the woman stops getting these injections. There's also reports of weight gain. Some women have quite a bit of weight gain, and they also report headaches. So some women cannot tolerate the Depo-Provera for very long. In the Depo-Provera, there needs to be a backup for 7 days after the first injection, and they need to be supplementing their diet with calcium and vitamin D to be able to absorb the calcium. There is a safety alert on page 670 that speaks to cautions in using oral contraceptives for women. Now, the oral contraceptives come in containers with both estrogen and progestin, 21 or 28 day packs, and they are usually safe and reliable for most women. The side effects can decrease acne, which is an unintended use, but it does decrease acne in some women. It increases bone density, and the cautions are that women who smoke or who have had a stroke or who have hypertension should not use these. Obesity increases the risk for thrombolytic problems, and some of the side effects are nausea, weight gain, breakthrough bleeding, breast tenderness, bleeding, and headaches, and they may increase cervical cancer in women. So the really signs that they need to look for warning signs include shortness of breath, chest pain. Any of those two symptoms must be reported. And again, in box 31.1, there is a box that lists the benefits, the disadvantages, and the risk for these oral contraceptives. The risks, some of the risks include that they provide no protection against sexually transmitted diseases, and as I said earlier, they may increase the risk of cervical cancer, and there's an increased incidence of deep and superficial vein thrombosis with use, pulmonary embolism, myocardial infarction, a stroke with smoking, and hypertension, chlamydial infection, because it does not prevent against this, and chlamydia is the most common sexually transmitted infection in our United States, and then gallbladder disease. The disadvantages of these, they must be taken every day or near the same time, especially progestin-only pills, or they cause breakthrough bleeding. And the side effects may include breakthrough bleeding, nausea, headache, breast tenderness, chloasma, which are the brown spots on the face, and amenorrhea may be seen as an advantage to some women. And the benefits are that these pills are unrelated to coitus and highly effective contraception. They're 91 to 98% effective if they're used correctly. And they do regulate menstrual cycles and reduce dysmenorrhea, menstrual blood loss, and associated anemia. Amenorrhea is also a benefit, or it may be seen as a disadvantage. Fertility does return within 3 months, usually after the discontinuation of the oral contraceptive use, and there is a decreased incidence of premenstrual dysphoria disorders symptoms, PMS, premenstrual syndrome, and there's a chance for benign breast disease, pelvic inflammatory disease, because again it does not prevent against contracting sexually transmitted diseases. Self-penigitis, and ectopic pregnancy can occur. Ovarian cancer can occur with use, and endometrial cancer because it sometimes produces thickening of the uterine lining. And then there's a risk for colorectal cancer. Again, it improves acne, endometriosis, many premenstrual syndromes, dysmenorrhea, breast bleeding from the fibroids will be improved because of the decreased bleeding. And there's also bone mass, combined oral contraceptives only. It improves bone mass, and it improves hirsutism, which is excessive hair growth on the face, and it improves rheumatoid arthritis. So all of those potential benefits are part of the use of oral contraceptives. For the safety alert on page 670, it lists the areas of caution with the thrombophlebitis, the thromboembolic disorders, and the cerebrovascular or cardiovascular diseases. Again, any estrogen-dependent cancer or breast cancer, benign or malignant liver tumors, hypertension, that's the main one, and migraines with an aura, or women older than 35 years of age having migraines without an aura. Diabetes longer than 20 years duration with vascular or other organ involvement. That is a caution for the use of oral contraceptives. And combined oral contraceptives should not be used by women who have any of the following: any impaired liver function, suspected or known pregnancy, undiagnosed vaginal bleeding, age older than 35 years, and any smoking at all. It's contraindicated for combined oral contraceptives. Major surgery requiring prolonged immobilization. So the not being mobile would be contraindicated for women to use oral contraceptives, the combined oral contraceptives, because of the increased risk for thromboembolism. And this is another warning signs to report when taking oral contraceptives. The acronym here is AICS, and A is for abdominal pain, which would be severe abdominal pain, and then chest pain with dyspnea, bloody sputum, or cough, or a cough, headache, severe weakness or numbness of extremities, hypertension goes along with that, and then eye problems, blurred vision, any problem with your eyes, that would indicate severe hypertension, and then severe leg pain or swelling, shortness of breath, speech disturbance, heat, redness or of thigh or calf. So all of those would be indicative of a blood clot and possibly an emboli. and this is what you would teach your women when using oral contraceptives to look for. Oral contraceptives can interact with other medications, drugs that stimulate metabolism in the liver, such as St. John's wort, and some anticonvulsants can alter the effectiveness of oral contraceptives. Most broad-spectrum antibiotics and antifungals do not decrease oral contraceptive effectiveness. The woman should always tell her healthcare provider and her pharmacist about other drugs she is taking. Some antimicrobials, such as ampicillin and tetracycline, can be impacted if the woman is also taking the oral contraceptives. And as I said, anticonvulsants, rifampin, barbiturates, and St. John's wort. Barbiturates and phenytoin sodium daily will reduce the effectiveness of the pill. So this is something to consider. So all of these things taken into consideration, she may want to choose another form of contraception. Emergency contraception, otherwise known as the morning after pill, is a method of preventing pregnancy. The Plan B must be taken no later than 72 hours after unprotected sexual intercourse and may need to be repeated 12 hours after the first pill. And that depends on the type of pill purchased. There are at least 2 types of emergency contraceptions on the market. In what types of situations would this type of contraception be used? Well, sometimes it is used after a sexual assault. Also, when the last Depo-Provera 4 months ago was given, but it's been past that 12-week period where the Depo-Provera would need to have been given, and then the person may have not been able to get that last Depo, and then they were using condoms, and then maybe they had a mishap with the condom. Also, potential complications with this method. Well, first of all, with one of the type of emergency contraceptions that are on the market, olapristal acetate, or ELA, it is one of the emergency contraception pills that can be purchased, and it inhibits implantation of the conceptus, but pregnancy should be excluded before this drug is taken because it can interfere with an existing pregnancy. Emergency contraception involves taking 1 or 2 tablets that contain a high dose of progestin, and it reduces the risk of pregnancy by approximately 85%. The combined oral contraceptives in larger than usual doses can also be used for the same purpose. The dose varies with the brand and may require taking a large number of tablets. Emergency contraception is most effective if it is used as soon as possible within 72 hours of intercourse, but can be used with lessened effectiveness within 120 hours. ELA can be taken within 5 days of unprotected intercourse, and emergency contraception will not prevent pregnancy if unprotected intercourse occurs after the emergency contraceptive is used. The transdermal contraceptive patch is another method of contraception. The ethinyl estradiol and norelgestromin transdermal contraceptive patch, or in other words, Ephedrine releases small amounts of estrogen and progestin that are absorbed through the skin to suppress the ovulation and make cervical mucus thick. It regulates, this method regulates menstrual cycles, and a non-hormonal contraceptive should be used during the first week of use unless the patch is started on the first day of the menstrual cycle. The patch is applied to clean, dry, non-irritated skin, either on the abdomen, the buttock, or the upper torso, and the breast should be avoided. The woman can also use this patch on the upper outer arm. It should not be placed over areas where lotions or oils have been used, or where it will be rubbed by clothing, because it could detach the patch. So this patch is worn for 3 weeks, a new patch every week for 3 weeks, and they are worn continuously for 7 days each. And then no patch is worn during the 4th week, and during the patch-free week, the woman has her period. After 7 patch-free days, she applies a new patch and begins the cycle over again. Women can have extended cycles without menses by using patches for several cycles or continuously. They should not be cut or altered in any way, and no more than 1 patch should be worn at a time. The patch usually adheres to the skin, and even in the shower or when exercising or swimming. About 5% of patches detach, and if that happens, the patch should be replaced with a new patch if the old one cannot be reattached. The day the patch is changed does not change, even if a replacement for a detached patch is necessary. If a patch is detached for more than 24 hours, or if there is a delay of more than 2 days within a cycle, a new patch is applied to start a new cycle. And the patch change day will be the day of the week the new patch is applied. Backup contraception is necessary for 1 week of the first cycle. The side effects include spotting, especially during the first 2 cycles, breast tenderness and skin reactions, and other side effects and risk are similar to the combination oral contraceptives. The patch may be less effective in women who weigh more than 198 pounds, and the risk of venous thromboembolism may be higher with the patch use than with oral contraceptives, because the estrogen exposure is 60% higher over time when patches are used. The contraceptive vaginal ring is another form of contraceptive use, and women using the ethinyl estradiol contraceptive ring or NuVa ring insert a soft, flexible ring into the vagina and leave it in place for 3 weeks. And this ring releases small amounts of progestin and estrogen continuously to prevent ovulation. After 3 weeks, the woman removes the ring and bleeding occurs, and then a new ring is inserted to begin the next cycle after the old ring was removed. A prescription is required, but there is no fitting or particular placement in the vagina that is necessary. Unless a ring is inserted on the first day of menses, a backup contraception should be used during the first 7 days of the first cycle. And the side effects, such as breakthrough bleeding, are less common than with oral contraceptives, and some women experience expulsion, vaginal discharge, or discomfort because they feel the ring in the vagina, so sometimes this ring can come out. Although some couples feel the ring during intercourse, it is not generally a problem, and the ring can be removed for short periods. However, if more than 3 hours elapse, a backup method of contraception is needed until the ring has been used continuously for the next 7 days. If the woman desires extended cycles, she can insert a new ring at the end of the 3rd week and avoid withdrawal bleeding. So, as I said earlier, teenage girls usually do not like this type of contraceptive method because they find it to be uncomfortable. And the barrier methods include chemical barriers such as spermicide and creams and gels, and then your mechanical barriers such as a diaphragm with use of spermicide. They are fitted by the provider because they come in different sizes. The resize has to, the size has to be refitted whenever a woman gains weight or loses weight, and also after a pregnancy has ended and the woman delivers a baby. And then there is a cervical cap, which also has to be, may have to be sized after delivery of the baby. And then there's a male condom. This is used usually with spermicides and water-soluble lubrication. And then there's a female condom, and also spermicides, creams, foams, gels, suppositories, and films. And then you have the sponge and cervical cap or Lee's shield. And there are 2 types of female condom. The female condoms are also called a vaginal pouch, and it is a polyurethane or nitrile sheath inserted into the vagina. A flexible ring inside the closed end of the condom fits over the cervix like a diaphragm. Another ring extends outside the vagina to partially cover the perineum. And the female condom is the first contraceptive device that allows a woman some protection from STDs without relying on the male condom. Male and female condoms should not be used together because they may adhere to each other. And the sponge, this method absorbs semen and contains its own spermicide, and it moistens with water until sudsy. There is no need to use lubrication with this method. There's no need to use additional spermicide, and the woman leaves it in place for at least 6 hours, and it provides protection up to 24 hours. The diaphragm is used with spermicide. It is fitted by the provider and resized with weight gain or weight loss. And again, the cervical cap can stay in place for 48 hours and should not be removed for 6 hours after intercourse. The male condom uses spermicides and water-soluble lubes. And then we talked about the female condom. And the film use, it needs 30 minutes before intercourse, and with these methods, it is not recommended to douche for 6 hours. And this is a picture of a female condom, and you can see the closed-ended end with the inner ring that fits up against the cervix, and then there's an open-ended ring at the very end, or the opening of the vaginal vault. So it is placed, and this gives the woman protection from sexually transmitted diseases, and she has control of this. And then we have natural family planning, and this method is also called fertility awareness or periodic abstinence methods, and it uses physiologic cues to predict ovulation, and it avoids coitus when conditions are favorable for fertilization. So these methods can also help women who want to become pregnant, and the methods are based on the knowledge that the ovum may be fertilized for approximately 24 hours and that most sperm live only 48 hours in the female genital tract, but some may live up to 80 hours. Natural family planning helps women learn about their bodies, how they change throughout the menstrual cycle, and this method is acceptable to most religious groups and avoids the use of drugs, chemicals, or devices. However, couples must be highly motivated because they must abstain from intercourse during as much as half of the menstrual cycle. Although the methods are very effective if used perfectly, the overall failure rate for this is typically 24%. And the methods are very unforgiving, and errors in predicting ovulation can lead to pregnancy from having intercourse during the fertile time. Women often combine the various fertility awareness methods to improve effectiveness. And some women use the methods to determine when they are fertile and use another contraceptive at that time. For additional information, there is a website that is a Planned Parenthood website that can be used. But there are calendars or rhythm methods. And the calendar of rhythm method is based on the timing of ovulation approximately 14 days before the onset of menses. The couple must abstain or use another method during the days calculated to be fertile. And this method is considered to be unreliable because of many factors such as illness or stress that can impact the timing of ovulation and change the timing of ovulation. The standard days method is a method that uses a string of color-coded beads to help keep track of the fertile and infertile days of each cycle, and it can be used by women with cycles that range from 26 to 32 days in length, but is ineffective for other women. Days 8 through 19 are considered their fertile days. And then there is the cervical mucus and 2-day method, and this is also called the ovulation or Billings method. And the cervical mucus technique is based on changes in cervical mucus that are assessed by wiping it from the vaginal orifice with tissue each day, and there is no mucus for the first 3 to 4 days after menses, and then thick, sticky mucus begins to appear after the 4th day. As estrogen increases, the mucus changes to clear, slippery, and stretchy like egg white, quality known as spinnenbarket. And after ovulation, mucus decreases in the amount and becomes thick and sticky again. To prevent pregnancy, couples must avoid intercourse from the time the mucus is first present after menses until 4 days after the end of the slippery mucus. Intercourse is allowed only every other day where there is little or no mucus because semen interferes with mucus assessment. The 2nd day method is a simpler form of the method, and the woman assesses cervical secretions daily, and if she notices vaginal secretions of any kind today or yesterday, she considers herself fertile. If there were no secretions either day, she considers herself infertile. The symptothermal method combines assessment of basal body temperature and cervical mucus daily. And in addition, symptoms that occur near ovulation, such as weight gain, abdominal bloating, and Mittelschmerz, and this is pain on ovulation, or increased libido, a sexual desire, are noted. Some women also use an electronic hormonal fertility monitor, and this monitor is designated for women trying to become pregnant, but can also be used to avoid pregnancy by identifying fertile times in the cycle. And then, of course, we have abstinence, and that's avoidance of sexual intercourse and any activity that allows the sperm to enter the vagina. This is the only completely effective method of preventing pregnancy and STDs. Abstinence requires perfect use to be effective. And depending on the time within the menstrual cycle it occurs, intercourse without the use of contraceptive has been up to an 85% chance of resulting in pregnancy. So if it's not used completely, then it will not be effective, but it is 100% effective if it's used. Most women are not abstinent all of their reproductive lives, but many practice abstinence at various intervals. Some women practice abstinence as part of the time, but have other methods available to use if they decide to become sexually active. Periodic abstinence is also practiced by women using natural family planning methods. And abstinence-only education programs have not been successful in reducing teen pregnancy, and adolescents who choose abstinence need help to learn practical methods to reach their goal. They need to think through just what abstinence entails, and they should role-play situations that they might encounter so they know what to say and do as it becomes necessary. And then the least reliable methods of contraception include breastfeeding and coitus interruptus, which is the withdrawal method. Breastfeeding does inhibit ovulation because of the prolactin interference with the secretion of the gonadotropin releasing hormone and luteinizing hormone. The frequency, intensity, and duration of the breastfeeding practice are very important in inhibiting ovulation. Women who breastfeed completely, day and night, with no supplemental feedings may avoid ovulation and resumption of the menstrual cycle, and the use of formulas or solid food does decrease the breastfeeding frequency and can lead back up to ovulation. So ovulation generally occurs before menses, making it difficult to know when the menstrual cycle is resuming, and ovulation usually occurs by 6 months, even in women who fully breastfeed. So after 6 months, it's not reliable at all, and it's one of the most unreliable practices for preventing pregnancy. And then the coitus interruptus, that is also called withdrawal, and that is a removal of the penis from the vagina before the ejaculation occurs. And this method requires great control by the man and may be unsatisfying for both partners. Sperm that is spilled on the vulva can enter the vagina and cause pregnancy. Infertility care is a specialty, and many general practicing nurses meet people who are seeking help for infertility or who have had infertility treatment in varied settings, such as perioperative and maternity settings. So the nurse could be one of those people who the couple reaches out to. And achieving parenthood with infertility therapy is not always easy, and nurses who work in pediatric and psychosocial settings may have opportunities to counsel families needing help with parenting and changes in their personal relationships. The extent of infertility depends on how the problem is defined. Infertility is not an absolute condition, but instead is a reduced ability to conceive, and it is defined as strictly as the inability to conceive after 1 year of unprotected regular sexual intercourse. A more workable definition does not specify a time limit, but recognizes that the couple's infertility is involuntary, and the inability to conceive at their desired time has not been actualized. So from 6% to 12% of women in the United States cannot have a baby when they desire. So some couples delay childbearing until their mid to late 30s, and when a natural decline, that's when a natural decline in fertility begins. So that would just, be logical that they would have a little bit more difficulty during that time. So as improved diagnostic and treatment options become available, couples who might have accepted childlessness may now choose to enter infertility therapy or resume therapy they had abandoned. So women who want to have a child without a male partner also are served by infertility services. And some factors that present in the man include abnormalities of the sperm or oligospermia, and this may be impacted by alcohol infections or alcohol use, infections, toxins, and cocaine use. And so many factors can impair the number, structure, or function of the sperm. And acute illness may be temporary. Other conditions such as the genetic disorder are permanent. So a single finding or several findings may be abnormal. Normal daily variations in semen further complicate the evaluation of a man's fertility. Evaluation of the semen can reveal azoospermia, which is the absence of sperm in semen, or oligospermia, and that is a low number of sperm in the semen. The average number of sperm released in a single ejaculation is 35 to 200 million. 20 million sperm per milliliter of semen is considered the minimum number adequate for an assisted fertilization. And that may be important for you to remember. A sufficient number of normal sperm must move in a purposeful direction to reach the ovum in the fallopian tube. Abnormal sperm structures or movement reduces fertility regardless of the actual number of sperm. And inflammatory processes in the man's reproductive organs can cause the sperm to clump, inhibiting their motility and fertilizing ability. And other sperm look normal but are unable to penetrate the ovum. And some of the problems with these factors include abnormal hormonal stimulation and sperm production, or acute or chronic illness such as mumps, cirrhosis, or renal failure, infections of the genital tract, anatomic abnormalities such as a varicocele or obstruction of the ducts that carry sperm to the penis, or exposure to toxins such as lead, pesticides, or other chemicals, and then therapeutic treatments such as antihypertensives or anti-neoplastic drugs, or radiation for cancer. Excessive alcohol intake is also another reason for these problems. Use of illicit drugs, again, such as marijuana or cocaine, an elevated scrotal temperature resulting from febrile illness, repeated use of saunas or hot tubs, or sitting for prolonged periods can impact these problems. Immunologic factors produced by the man against his own sperm, such as autoantibodies, or by the woman, causing the sperm to clump or to be unable to penetrate the ovum. And then you have abnormal erections, and these abnormal erections reduce a man's ability to deposit sperm-bearing seminal fluid in the woman's upper vagina near the cervix, and erections are influenced by both physical and psychological factors. The central nervous system dysfunction, which can be caused by drugs, psychiatric disturbances, or chronic illnesses, can interfere with erections. And then we have spinal cord disorders and disorders or surgery affecting the autonomic nervous system that can also disrupt the normal erection. Peripheral vascular disease reduces the amount of blood entering the penis and thus reduces the ability to maintain an erection. And then abnormal ejaculation. This prevents deposition of the sperm in the ideal place to achieve pregnancy. You may have retrograde ejaculation, which is a discharge of semen into the bladder, and that can occur in a man who has diabetes or neurologic disorders. or has had surgery that impairs the function of the sympathetic nerves, or takes drugs such as an antihypertensive or psychotropics. And men who have suffered spinal cord injury may retain the ability to ejaculate depending on the level of the cord damage. And then we have abnormalities of the seminal fluid. The seminal fluid nourishes, protects, and carries sperm into the vagina until they enter the cervix. Only sperm enter the uterus. Most seminal fluid remains in the vagina because it contains prostaglandins that would cause an intense uterine contraction if large amounts enter the uterus. Semen coagulates immediately after the ejaculation, but should liquefy within 60 minutes to permit the forward movement of sperm. Seminal fluid that remains thick traps the sperm, impeding their movement into the cervix. And the pH of seminal fluid is slightly alkaline to protect the sperm from the acidic secretions of the vagina. Adequate fructose, citric acid, and other nutrients must be present to provide energy for the sperm to move forward in a woman's reproductive tract. Seminal fluid that is abnormal in amount, consistency, or chemical composition suggests obstruction, inflammation, or infection. And the presence of large numbers of leukocytes would suggest infection. And now we're going to discuss factors in the woman for infertility to be a problem. A woman's fertility depends on regular production of normal ova, also an open path for from her cervix to the fallopian tube to permit fertilization and the movement of the embryo into the uterus for implantation. It also depends on a uterine endometrium that supports the pregnancy after the implantation. And there are some disorders of ovulation, and they include abnormalities of the fallopian tubes or cervix, repeated pregnancy loss, abnormalities of fetal chromosomes, and abnormalities of the cervix or the uterus, and also endocrine abnormalities, immunologic factors, and environmental agents or infections. Normal ovulation depends on delicately timed and balanced secretions from the hypothalamus and pituitary and an ovarian response to mature and release the ovum. So that a lot of this happens at puberty. The hypothalamus secretes the gonadotropin releasing hormone in regular pulses. And in turn, that hormone causes the pituitary to release follicle stimulating hormone, and LH, and follicle stimulating hormone stimulates the maturation of several follicles in the ovary, and then the ovary matures and it secretes estrogen to thicken the endometrium. And then the LH, the luteinizing hormone surge, markedly stimulates the final maturation and release of one ovum from its follicle. And then the collapsed follicle from which the ovum was released, now called a corpus luteum, produces the progesterone and estrogen, which further prepare the endometrium. So this all works together to prepare an adequate environment for the implantation, as you remember in your anatomy and physiology. In regard to abnormalities of the fallopian tube, at least one fallopian tube is needed for normal conception and implantation. Tubal obstruction can be the result of scarring or adhesions following reproductive tract infections caused possibly by STDs, such as chlamydia or gonorrhea. They are responsible for many cases of infertility. And then you have the endometriosis, and this is the growth of the uterine lining Um, and it can cause tubal adhesions, painful menstrual periods, and painful intercourse, but the small lesions are unlikely to affect the tubal patency, but large lesions can distort tubal anatomy and lead to infertility. And then you have abnormalities of the cervix, and with estrogen levels from the ovary, when they peak twice during the menstrual cycle, once before ovulation and again approximately 1 week after ovulation. The first peak occurs approximately 2 days before ovulation and causes the woman's cervix to dilate slightly and produce a clean, thin, slippery mucus. And this mucus facilitates sperm passage into the uterus and prepares them for fertilization. Low estrogen levels prevent development of this mucus and are usually associated with anovulation. Also, polyps or scarring from past infections or surgical procedures can obstruct the woman's cervix. Abnormal cervical mucus caused by estrogen deficiency, surgical destruction of the mucus secreting glands, and cervical damage secondary to infection or other factors prevent normal movement of the sperm into the uterus and fallopian tubes that causes the fertilization. And then repeated pregnancy loss is another factor. Couples who repeatedly lose pregnancies have the same result as those unable to conceive, and that is no living child. And these recurrent losses can result from abnormalities in the fetus or placenta, or from maternal factors such as structural abnormalities or autoimmune diseases. And then also abnormalities of the fetal chromosomes can occur as errors in the fetal chromosomes, and they can result in spontaneous abortion, usually happening in the first trimester. These abnormalities often severely disrupt the development of the fetus and or the embryo or the fetus, and they cannot survive to develop to live birth. Maternal age-associated chromosome abnormalities in the ova increase spontaneous abortions and decrease live births in older women who conceive. We also have endocrine abnormalities and incompetent cervix, where the cervix cannot stay closed, and sometimes there are treatments for that where she can hopefully carry the fetus to a viable time in her pregnancy. Uterine myomas or fibroids and adhesions inside the uterine cavity can cause repeated fetal loss. And these lesions alter the blood supply to the developing fetus or cause uterine irritability, and that leads to preterm labor and birth. And many times the preterm birth causes the fetus to not be viable at the time of gestation. And with endocrine abnormalities, a lot of times it's the inadequate progesterone secretion that prevents a normal thickening of the endometrium, and the embryo does not implant, or it may implant poorly. Infertility related to menstrual irregularities and anovulation can lead the woman to have polycystic ovarian syndrome, and this happens more often with women who are obese. And this PCOS, the woman with PCOS who conceives and delivers successfully, she may have a problem with producing adequate milk for her infant needs. Also, hypothyroidism and hyperthyroidism are associated with the inability to conceive and with recurrent pregnancy loss. And this is because of the effects on the maternal blood glucose level and the vascular system are poorly controlled. From the poorly controlled diabetes can result in repeated pregnancy loss as well as many other complications of pregnancy. Immunologic factors are implicated in some cases of recurrent pregnancy loss, and some of these include systemic lupus, erythematosus, or SLE, and they're more likely to experience spontaneous abortions. And that appears to be related to thrombosis or other damage in placental blood vessels. And the women with SLE can have other complications during pregnancy, such as exacerbation of their symptoms, fetal heart block, fetal distress, and stillbirth. And then you have environmental agents. And some of these are well established in relationship to impaired fertility and pregnancy loss. We have diethylstilbestrol, or DES, and that and also other common toxic agents, including ionizing radiation, alcohol, and isotretinoin, or Accutane, and all of these suspected toxins are numerous. Some are cigarette smoke, and this anesthetic gas, organic solvents, pesticides, lead, mercury. All of these agents are directly toxic to the embryo or fetus, causing its death, while others interfere with the normal placental function necessary to sustain the pregnancy. Other factors that influence fertility include coital frequency, the number of times couples have sexual intercourse, the age of both parents, especially the woman, cigarette smoking, especially from the woman, although if the man smokes and the woman doesn't, she still has second-hand and third-hand smoke. Also the exercise, diet, and weight of both parents, especially the woman, emotional factors, medical problems, and drugs and chemicals. And then there is uterine malformations. The types of uterine malformations that can cause infertility or repeated pregnancy loss include the uterus having a single horn or unicornate uterus and only one fallopian tube, so that gives you a decreased chance of having an ovum fertilized by a sperm. And then we have single uterus with a midline septum. Also, a uterus having two horns or bicornuate with an indentation at the top. And then double uterus with one vagina, or double uterus and double vagina. So all of these would cause problems with fertility and or problems when the ovum is fertilized. It may be the uterus may not be able to carry a fertilized conceptus. Stenosis or congenital malformations of the cervix or uterine cavity can cause repeated loss of a normal embryo or fetus, and these malformations prevent the normal implantation of a fertilized ovum that is ready to implant. Cervical or uterine abnormalities and possibly hysterectomy also can occur after surgery or trauma from a previous birth. Painless and premature cervical dilation often occur in the second trimester with these, and it is characterized in women with an incompetent cervix. And although the woman can conceive, she is unable to carry the pregnancy long enough for the fetus to survive, to be born. And uterine myomas or fibroids, these are benign tumors of the uterine muscle, and adhesions inside the uterine cavity can cause repeated fetal loss. And these lesions alter the blood supply to the developing fetus or cause uterine irritability that leads to preterm labor and preterm birth. And the fibroid tumors sequester blood and alter the blood volume and the blood supply, so that becomes a problem. Assisted reproductive techniques, or ART, involve 4 types of intervention. One is in vitro fertilization, or IVF, or gamete intrafallopian transfer, or GIFT. Then there's a third, zygote intrafallopian transfer, or ZIT. And then the fourth is intracytoplasmic sperm injection, or ICSI. And with the in vitro fertilization, that is the most commonly used ART method. It bypasses blocked or absent fallopian tubes, and the physician removes the ova by ultrasound-guided transvaginal retrieval, or occasionally they use laparoscopy, and they mix the ova with prepared sperm and from the woman's partner or a donor. And the ova are examined for successful fertilization approximately 18 hours later, and then either returned to the uterus or cultured for 48 to 96 more hours, allowing 5 days of cell division. And the number of fertilized ova returned to an individualized is individualized, but is approximately 2 to 3 based on the prognosis for success, balanced against the woman's risk of multifetal pregnancy. Older women often receive more ova than younger women to improve their chances of a successful pregnancy, without greatly increasing the risk of having a triplet or higher pregnancy. The pregnancy complications in a single older woman are more likely, and she might lack the needed support in her pregnancy. And then supplemental progesterone is given to the woman to promote implantation and support the early pregnancy. The woman will not have a menstrual period even if she is not pregnant. And transvaginal ultrasounds are used to identify whether one or more gestational sacs have been implanted with in vitro fertilization, and to determine whether a tubal or ectopic pregnancy occurred after methods such as IUI or GIFT or ZIFT. The gamete intrafallopian transfer occurs and the woman must have at least one patent fallopian tube for GIFT to be an option. And the procedure begins in a manner similar that of the in vitro fertilization, using multiple retrieved ova and washed sperm. The ova are drawn into a catheter that also carries a prepared sperm, and the sperm and up to 2 ova per tube are injected into each fallopian tube through a laparoscope. And then additional prepared sperm may be injected into the uterus through the cervix to improve the chance of successful fertilization. And then with zygote intrafallopian transfer, or ZIFT, often called TET, this is a hybrid of the in vitro fertilization and GIFT, and the woman's ova are fertilized outside her body in an in vitro fertilization, but the resulting fertilized ova are placed into a distal fallopian tube and enter the uterus naturally for implantation. The woman must have at least one patent fallopian tube. And in comparison of the in vitro fertilization, the gamete intrafallopian transfer, and the zygote intrafallopian transfer, one advantage of GIFT is that some people and religious groups find that these procedures are more acceptable than the in vitro fertilization or the ZIFT because ova and sperm are placed directly into the woman's body. With in vitro fertilization and ZIFT, there is evidence of fertilization before placement in the uterus or the tubes, which reassures other people. So these are the methods of ART, and all of the ART procedures have some degree of invasiveness for the woman and possibly the man. And to obtain more ova and increase the likelihood of pregnancy with these procedures, a woman may undergo controlled ovarian hyperstimulation, and placement of the gametes or fertilized ova in the distal fallopian tube requires a laparoscopy, whereas in vitro fertilization can be achieved transcervically, making it the most common procedure. Tubal pregnancy may result if the embryos cannot reach the uterine cavity to implant. In vitro fertilization is approximately 99% of the is used approximately 99% of the time because it is less invasive, and higher rates of prematurity and low or very low birth weight infants have been linked to more frequent multiple births associated with ART. And this is just a diagram of the process of in vitro fertilization, which is the most commonly used method of ART. And you see the fallopian tube, you see the ovary, and the uterus, and the oocyte is retrieved by transvaginal or laparoscopic approach, and then they are a culture tube containing the retrieved oocytes is established, and then you have the cleavage or the cell division, and then after the conceptus is fertilized, after the ovum is fertilized by the sperm, causing the conceptus to divide cells, then after a time, after so many hours or days, then it is implanted into the uterus, and so there you have the embryos placed in the uterine cavity, and there they will implant, hopefully, and the pregnancy will be, hopefully the woman will carry those fetuses to term, or to hopefully to at least close to term. Therapy for infertility include medications such as hormone treatments. Clomiphene citrate is the most common drug used to stimulate an increase in the amount of hormones that support the growth and release of a mature egg. And that another brand name for that is Clomid. And Clomid is also used in men when there is a low sperm count caused by low testosterone levels. Other medications used are letrozole, bromocriptine, or cabergoline. All of these drugs can be used for treatment of infertility. Surgical procedures, as we've just talked about, can also be used to remedy certain problems with anatomical structures, or to remove fibroids, things like that, if they have repeated pregnancy losses. Due to the fibroid tumors, therapeutic insemination can be used, and that is insemination of semen from other donors. Also, surrogate parenting, where there is a surrogate mother who carries a child for the couple, and that can either be using her ovum, or and she can be artificially inseminated by the male partner of the couple, or she can use IV in vitro fertilization can be used with the woman, with the female partner of the couple. Gift can be used, TET can be used, and ZIFT can be used. And then there are microsurgical techniques that augment and facilitate the successful pregnancy. And of course, the outcomes that we want to see are the achievement of a pregnancy to viability. Sometimes these attempts are unsuccessful, and we have to look at psychological reactions such as guilt and isolation and depression, and stress on the relationship of between the couple. Pregnancy loss after treatment could occur, and this is really a sad thing. Couples who suffer pregnancy loss after infertility therapy may interpret the experience with mixed feelings of loss and gain. And couples undergoing infertility evaluation and treatment are often aware of pregnancy much earlier than fertile couples, and they want to hope yet expect to be disappointed again. If a miscarriage or birth before fetal viability occurs, they may grieve profoundly for what they achieved and then lost. And yet, despite their grief about the pregnancy loss, the partners may be encouraged because they have proved that they can achieve a pregnancy, and they may feel that if they succeeded once, they can do it again. And then there are many legal and ethical issues surrounding surrogates and parental rights, and there are ethical issues in relation to cloning and the experimentation of DNA and all of this whole issue of using experimental cloning. And so that is one thing in itself that can be debated. And then there are the sale of frozen embryos, and that is also can be an ethical issue. Nursing care related to the infertility treatment just focuses on supporting the couple and teaching coping skills. And of course, if you're a nurse who is working in these areas of infertility clinics, then you would need to know the exact techniques and the exact medications that are used, and just be available to the couple and to the physicians and to the other nurses to work as a team during this time. And so we do as nurses, we advocate for our patients, and we do support positive coping skills. A couple's initial reaction to infertility is often one of shock because the partners are usually healthy and don't expect to have problems conceiving. And their reactions vary according to how easily their infertility is alleviated. And their personalities and self-images and the strength of their relationship also plays an integral role in this whole process. Guilt is something that they many times have to deal with. The partner having the only identified problem might feel that he or she is depriving the other of children. And this feeling can be compounded if the normal partner has children from another relationship. It may be difficult for this person to understand that not all factors affecting fertility can be detected, and that what seems like the one partner's problem is often the couple's problem. And guilty about past choices that now affect fertility can be felt by either partner. A woman with adhesions resulting from a sexually acquired infection may regret her past choices. The man who wanted to delay pregnancy longer than the woman may feel guilty if her age is now limiting the time she has for conceiving. And then isolation. Infertile couples often feel different from friends and relatives who do not have difficulty conceiving. To insulate themselves from painful reminders of their infertility, they may want to withdraw from these relationships, and some couples develop supportive relationships with others who are also infertile, which somewhat diminishes their sense of isolation but may increase it if one of those couples conceives. Then you have depression. One or both partners may experience depression as their sense of competence and control over their bodies is challenged, especially if therapy is not successful quickly. And they often feel as if they are on a roller coaster or hope alternating with despair. When the woman has her menstrual period each month, in an attempt to insulate themselves from disappointment, couples with long-term infertility try not to expect too much with each cycle. And the couple may feel envious of those who conceive easily. They may become judgmental and angry when they see those who seem to have no business having a baby, such as an adolescent or a woman who abuses drugs or a woman who cannot support an added child. So they feel all of these feelings, and then there's stress on the relationship between the couple. Because infertility can challenge one's identity and self-esteem, the partners may find less satisfaction in their relationship, and they actually feel unlovable and unappealing to their mates. And the man may find it difficult to perform on demand for examinations that require him to ejaculate, and feeling that others will judge his sexual function. And the fact that semen samples are best obtained by masturbation is unacceptable to him many times. And both partners are stressed when intercourse must be scheduled to coincide with specific evaluations or with ovulation. Intercourse can become a chore or a medical procedure more than an expression of love. If sperm from an anonymous donor is used for therapeutic insemination or other techniques, the man may feel that his masculinity is further threatened, and he may have difficulty distinguishing fatherhood as a biological achievement from fatherhood as a relationship with his child. And the partners find their relationship strained if they disagree on which treatments are appropriate and how long they should be pursued. One partner may want to keep trying, and the other partner may want to just abort the process of trying, and I'm sure there are financial concerns as well. If they are considering adoption, their relationship may be strained if they differ on whether to adopt and what kind of child they are willing to accept. And then there are cultural and religious considerations, and ethical considerations. Some couples fear adopting a child because a woman might become pregnant afterwards, and although pregnancy has been the goal for a long time, they may worry that they would love their adopted child differently from their biological child. And adoption of children from abroad usually requires multiple trips to the nation to complete documents and multiple interactions with the child they hope to adopt. And adopting children from orphanages in foreign countries carries the risk of having a developmentally delayed child because of limited interactions with adults or other children. So many things can cause emotional roller coasters for the couple. Um, so all of these things, and there is much to read in your text, a lot of good information in your text to read. Some methods of evaluation of infertility for the male partner include the semen analysis to analyze semen from the male, also endocrine tests to test for different types of endocrine problems, hormonal imbalances of the male, also ultrasonography, which uses ultrasound to examine and analyze the male anatomy, and then testicular biopsy. And then for the female, we do have ultrasonography again, postcoital tests, and for the postcoital test, several hours after intercourse, sexual intercourse, a vaginal speculum is inserted to see the cervix of the female, and a catheter with a syringe aspirates mucus from the cervix, and then the mucus is placed on a slide and examined under a microscope, and they are looking for the presence of active sperm. Of course, we know that the sperm must swim through cervical mucus from the vagina through the cervix and into the uterus. Several hours after intercourse is when this happens, and it needs to happen during the periovulatory phase of the female. So all of this is additional testing that has to occur to evaluate the effectiveness of the sperm moving through all of that mucus and through the cervix and into the uterus, and how this is happening and what's preventing it from happening. And then we have also endocrine tests of the female, and this tests for imbalances in hormones, and could be several different types of imbalances. And then the hysterosalpingogram evaluates the fallopian tubes themselves to make certain they are patent and would allow a sperm to travel to meet the ovum in the fallopian tube. And then we have endometrial biopsy that can evaluate the endometrial tissue where the ovum, where the fertilized ovum or the conceptus is implanted, and what problems might be occurring in the endometrium. And then we have hysteroscopy, which visualizes, is able to, with a scope, is able to visualize the uterus and all of the anatomy of the uterus and check for problems there. And so all of these things are available to the couple. And now we have some questions. A physician prescribes clomiphene citrate or clomid serophene for a woman experiencing infertility. She is very concerned about the risk of multiple births. The nurse's most appropriate response is it A, this is a legitimate concern. Would you like to discuss this further before your treatment begins? B, no one has ever had more than triplets with clomid. C, ovulation will be monitored with ultrasound so that this will not happen. D, 10% is very low risk, so you don't need to worry too much. And the answer is A. The correct answer would be, this is a legitimate concern. Would you like to discuss this further before your treatment begins? So this is a legitimate concern, and the woman really needs to discuss this thoroughly and get all of the information prior to this procedure. Now we'll look at some sexually transmitted diseases. And a sexually transmitted disease is defined as any infection that can be transmitted through intimate contact with the genitals, mouth, or rectum, or of another individual. And please look at page 796, chapter 32, for your reading here. We'll be discussing chapter 32 next week, but we're going to go ahead and look at these sexually transmitted diseases here because there's so much information to be covered. And the objectives here with the sexually transmitted diseases, or STIs, sexually transmitted infections, are to describe the care of the woman with an infectious disorder of the reproductive tract, including sexually transmitted diseases, pelvic inflammatory disease, and toxic shock syndrome. And these are the types, the different types of sexually transmitted infections. We have fungal or bacterial, which includes candidiasis, trichomonas, bacterial vaginosis, chlamydial trachomatis, gonorrhea or GC, syphilis, and pelvic inflammatory disease or PID. And then for the viral infections, we have herpes simplex virus 2 or HSV-2, condylomata acuminata, and then we have human papillomavirus or HPV, and we have hepatitis B and HIV and AIDS. And just a question, what puts the patient at greatest risk for developing cervical cancer? Is it a history of fibroid tumors, repeated gonorrheal infections, a history of endometriosis, or a history of human papillomavirus? And the answer is a history of human papillomavirus. And several strains of human papillomavirus are found to cause cervical cancer, and it is a great risk for cervical cancer, and that is why we perform PAP and HPV tests or co-testing on women beginning at 25 years of age. And this is one of our sexually transmitted diseases that we are looking at today, and the signs and symptoms include genital redness and swelling, itching and burning, a foul discharge, urethritis and prostatitis for the man, strawberry cervix, which is what you see here on the screen, and you see the little areas that look like a strawberry seed, strawberry seeds that are there all over the cervix. And it thrives in alkaline states, and it can lead to prostate inflammation in the male if left untreated. The diagnosis of trichomonas is with microscopic exam, a wet prep, and a test of cure. After the treatment, we have to have a test of cure to make sure it has resolved. And the interventions include Flagyl, 2 grams, and the partner must be treated, or else we're going to be reinfected. And then we have bacterial vaginosis, or BV, and the causes of bacterial vaginosis include Gardnerella vaginalis, and also douching can cause a imbalance of flora in the vaginal vault, and that can be a cause of bacterial vaginosis. And then we have also multiple partners can also be a causative factor. So the signs and symptoms, are a thin grayish white discharge, also a fishy odor, and on a saline wet mount, the identification of clue cells, and these are clue cells on the screen here, and that's what they look like, and that's what we're looking for on the slide when we look at this under a microscope. The diagnosis is a whiff test. It's actually taking a whiff of the specimen after you collect it from the vaginal vault, and it's going to, as we say, it's going to smell like a fishy odor. It's going to smell fishy. And then when we put the specimen on a slide and put it underneath the microscope, this is what we see are the clue cells. That's how we diagnose it. And then the treatment is flagyl, oral flagyl, or clindamycin or Cleocin cream. And some of the nursing considerations are teaching the patient how this happens, how to prevent, how to treat, how to ensure that this resolves for them, and then how to treat. Also, excuse me, this does not have to be something that their partner gave to them from being unfaithful. So it can occur by just, like we said, by having Gardnerella vaginalis infection. So that does not have to be about unfaithfulness or a partner that has been unfaithful and bringing back something to the woman. So it could be, but it does not have to be. So that should be a nursing consideration where we're teaching the woman about the origin of the condition. And we need to teach the woman to refrain from sexual intercourse or use a condom. And we do not have to treat the male partner. It has been found to be not beneficial when treating the male partner with bacterial vaginosis. And then we have to teach the patient about the drug that we are using to cure this. And this is the flagyl, and we teach to avoid alcohol while taking the flagyl, so that's very important. And in your nursing drug cards, you can look further into flagyl or clindamycin and the cream. And then also you need to just be an advocate for this patient as you normally would, and then follow-up care per the physician's order. Chlamydia. This is the most common sexually transmitted disease according to the CDC, and the problem with chlamydia is that it is usually asymptomatic. Patients usually can have a yellowish discharge, but it doesn't cause alarm. So it can be considered asymptomatic in men and women. They can have painful and frequent urination. They can have abdominal pain. They can have fever and nausea. A swollen and tender testicles is sometimes a sign and a symptom, and this can lead to infertility if not treated. And so we need to make sure that we test for this when we see clients in clinics for annual exams, because this is very, very common in our population, and it is contagious, and so we need to make sure And males can get urethral infections with chlamydia. The chief cause of tubal scarring with pelvic inflammatory disease, it travels through the cervix and could infect the uterus and the tubes and the fallopian tubes. So this is very, very important that we assess for chlamydia. And as we said, there may be yellow discharge with chlamydia. We should treat both the gonorrhea and chlamydia at the same time, and the treatment is usually azithromycin or Zithromax or doxycycline or fibromycin. That is contraindicated in pregnancy. And then we can add ceftriaxone or Rocephin for co-infection with gonorrhea. Erythromycin is the treatment in eyes within 1 hour of birth with pregnant women or laboring women that are found to be infected with chlamydia. The diagnosis, back up a little bit, the diagnosis is a culture with a discharge and a urine test. And the interventions, of course, are antibiotics that I just mentioned. And for babies, the ophthalmic ointment is given for the babies that are born to women who are infected with chlamydia during right before the birth of the baby. We must treat all partners, and we must do a test of cure after the treatment to ensure that the infection is resolved. Gonorrhea is caused by Neisseria gonorrhoeae. It's characterized by purulent exudates. The signs and symptoms for men are urethritis, discharge, and epididymitis. For women, a pelvic and lower abdominal pain occurs. Pelvic inflammatory disease may occur, full-blown pelvic inflammatory disease, and urethritis may be present, and menstrual problems can occur. And this can be spread by genital to genital contact, but also anal to genital contact or oral to genital contact. Most women are usually asymptomatic, but with men there's a green discharge. And again, this can be cultured with chlamydia and chlamydia test and gonorrhea test can be done concurrently, and then of course the Rocephin can be given. The diagnosis can be a positive urethral, vaginal, or urine culture, and the interventions are antibiotics. We treat all sexual partners, and there is an antibiotic eye drops for an infant that has been born to a woman who has gonorrhea, because the gonorrhea can infect the infant's eyes. Dual treatment is recommended. The treatment is completed for the infants born to the women who have gonorrhea. It can cause blindness in infants, and cefixime or Suprex oral 400 milligrams can be given. The drug of choice is Rocephin 250 milligrams intramuscularly. That's the first line treatment, and both partners should be treated and a condom used until retested for cure of treatment. And azithromycin for possible chlamydia is given, because gonorrhea and chlamydia are often infections, concurrent infections. And because of the high reinfection rates, we need to retest in 3 to 6 months. And then we have syphilis. There are 3 stages of syphilis. The latent phase involves the heart, blood vessels, and the central nervous system, and then can cause heart disease, blindness, and brain damage, and it can lead to death, and it can stay in the body for years. The causes are treponema pallidum. The signs and symptoms in the primary stage, it is a painless canker. It occurs on the genitals or the mouth. The secondary stage causes flu-like symptoms, and enlarged spleen and liver, can cause a headache and a skin rash. And the skin rash is often on the palms and the feet, the soles of the feet and the back. And there are condylomatous growths that occur on the genitals. And then the tertiary stage, that is where the neurological and the cardiovascular complications occur, and there can be brain damage and there can be death that occurs with this stage, if it reaches this stage. And the serological test, a blood test, includes the VDRL, the RPR, that's a very common one, and then the ELISA is used, and the FTA-ABS, and then the interventions are penicillin G is a drug of choice, and again, it can stay in the body for several years if left untreated. It is treated with antibiotics and needs follow-up testing in 3 and 6 months. And this is a reportable sexually transmitted disease. So it has to be reported to the health department, and it is these reports are then sent to the state health department, and they are tracked there. And this is about genital herpes, and the signs and symptoms include vesicles and ulcerations, flu-like symptoms, lymphadenopathy, urethritis and cystitis, and we have herpes simplex virus 1. It causes oral pharyngeal infections, and then herpes simplex virus 2 causes genital lesions. And herpes genitalis is an STD caused by the herpes simplex virus, and blisters appear with this virus within 2 to 12 days after introduced to the infection. And the signs and symptoms include multiple painful vascular lesions of blisters, and they can last 7 to 21 days. The these blisters can go away. They can be treated, or then they can go away on their own, and then they can reactivate later. And so they have outbreaks of these. This is not a curable disease. It is treatable. The symptoms are treatable, but it's not a curable disease. The virus reactivates during stress, may reactivate during menses, or during fevers. So it can come back. It can reoccur over and over again. And herpes, there is no cure for herpes. It is caused by the herpes virus. The treatment to shorten or prevent outbreaks is Zoravax or aciclovir or valcyclovir or Valtrex. And Health teaching involves helping the patient manage the disease with the least possible disruption in lifestyle and relationships. And making sure they understand the disease process helps gain a sense of control for these folks. Women should abstain from sexual contact while the lesions are present. They should be using latex condoms for each sexual encounter because viral shedding can occur at any time. If a woman is pregnant and has herpes, and if the lesions are active, a cesarean birth is needed. And of course, the diagnostic tests are cultures. Also, a Western blot can be used. And interventions include the antiviral medications that I mentioned. And again, the cesarean delivery is completed to protect the baby from this disease. Condylomata or HPV warts. These are dry wart-like growths. The diagnosis is a colposcopy, a biopsy, and an abnormal pap can identify these. And the interventions include cryotherapy or freezing of these lesions. Also, electrocautery can be used. Topical agents have been used to remove these, and the interferon therapy can also be used. This disease puts the client at higher risk for cervical cancer. Certain strains of HPV have been directly linked to cervical cancer. So with these patients, they need a pap smear annually to make certain that they are not developing cervical cancer. Some of these lesions can be cleared by young women with intact immune systems, but as the women become older, their bodies can no longer clear these lesions, and they can contract cervical cancer and need surgical techniques completed to protect them from developing full-blown cervical cancer. All sexual partners must be treated. There is no cure. They will have reoccurrences. Vaccines are available, such as Gardasil, and there is another vaccine available, but they usually are given in childhood, ages 9 on up to age 25. They can be given to prevent this from occurring initially. So, but if they're already there, there's really no cure unless the body's immune system clears it. And so, again, the high-risk strains can cause the full-blown cervical cancer to occur. And so risk for cervical cancer with HPV, the causes are human papillomavirus, and the signs and symptoms are just the genital warts. And again, if the pap result comes back, they may not have genital warts that are visible, but if a pap test comes back for positive HPV, or an abnormal pap is found, then they will test for HPV, and then that is called co-testing, and so then they will decide how to treat that woman if she is if the cervix is affected. This picture here shows a male who has the genital warts, and so Gardasil vaccination for boys and girls are available, and that is offered to boys and girls ages 9 through 25 or 26 years old, and it has 3 doses. And that is what is available right now. And then we have HIV, and this can be infected for several. A person can be infected for several years without symptoms, but some of the symptoms include weight loss, vaginal yeast infections, recurring vaginal yeast infections, oral thrush of the oral cavity, also flu-like symptoms, and they must have consent to tests verbally or written. And these tests are routine at the prenatal visits. They still have to have consent to have the test done. There is no cure, but treatment is available to reduce the viral load of HIV. Prevention is key, and we must, as nurses, we must talk about how to prevent oneself from contracting HIV. And one way is just to limit sexual partners, not engage in risk-taking behavior, sexual behavior. Persons with HIV must avoid breastfeeding, and they must have a cesarean birth at 38 weeks. So HIV impacts many organs in the body. It can be found in tears, saliva, breast milk, amniotic fluid, semen, urine. Transmission is sexual contact and contact with blood, and perinatal transmission has a vertical transmission. So HIV is contraindicated during labor. Having the woman labor is contraindicated with an HIV infected woman. And the episiotomy during labor is contraindicated. Vacuum extraction, forceps, internal fetal monitoring, all of those are contraindicated. The woman must have a C-section at 38 weeks. And so here on the screen you see that acute HIV infection includes some of the signs and symptoms, includes having weight loss, having fever. They may have malaise. They may have neuropathy. They may have headaches. They may have sore throats frequently, pharyngitis. They have mouth sores and thrush in their mouth, a yeast infection of the oral cavity. They have enlarged lymph nodes and lymphadenopathy, enlarged lymph nodes throughout their body. They may have a skin rash. Their esophagus is impacted with sores throughout. And then they have myalgia, pain of the muscles. And over the liver and spleen, they have an enlarged liver and spleen that can be palpated and felt. Per the physical assessment, they also can have nausea and vomiting frequently. So, and they must be tested. They would be, for a woman who is pregnant with HIV, she would be considered as a high-risk pregnancy, and she would have to be have special treatments at each prenatal visit. She'd have to have frequent prenatal visits. And then pelvic inflammatory disease. This happens when the pelvic cavity is infected, and you have an infection in the pelvic cavity, and it is caused by several bacteria, and it may be caused by gonorrhea and chlamydia. We can also have cervicitis during this with this disease, and endometriitis. And salpinginitis infection, infection of the fallopian tubes, and it is diagnosed by pelvic exam, and it causes extensive tubal scarring, and it also causes infertility with this disease. This does not occur in men because men do not have a uterus and endometrium and fallopian tubes, and so their pelvic cavity doesn't. They just don't have the organs that could have this pelvic inflammatory disease in it, this can cause ectopic pregnancies to occur because of the scars and the scarring of the fallopian tubes, and it causes the Contraceptives to implant before it reaches the uterus. And the risk factors for pelvic inflammatory disease include multiple sex partners, having sexually transmitted diseases, substance use, because we're not in control when we abuse substances, so it leads to risky behaviors. Frequent douching can occur, can cause pelvic inflammatory disease. IUD use can lead to pelvic inflammatory disease because IUD and multiple partners for sexuality can lead to infections of the uterus. IUD requires the cervix to be open a little during the use of the IUD, and that is the reason that microorganisms are easier to infect the uterus. The treatment are antibiotics, and these women are usually hospitalized, and they're usually on bed rest. Other signs and symptoms include chronic lower abdominal pain, the purulent vaginal discharge, and bleeding. And they usually have pain with intercourse. They usually have nausea and vomiting, and pain on urination, and also fever and chills. And there are some nursing interventions on page 800 that I want you to look at. The laparoscopic surgery for adhesions, to remove the adhesions, is available with, and some women are candidates for this. And then, of course, STD testing to see if they currently have sexually transmitted diseases going on. Education for decreasing their risky behavior, and sometimes this can be asymptomatic. And then toxic shock syndrome. This is life-threatening. It is a condition resulting from an infection with a toxin-producing strain of Staphylococcus aureus. And the contributing factors include high absorbency tampons that possibly have been left in longer than they need to be, and also the use of diaphragms. There are reportable sexually transmitted diseases. That means that once they're diagnosed, they have to be reported. It's a law, and these laws vary by state or province, and this does include notification of contacts, and however many contacts the person has had, they have to be contacted, and they have to come in for treatment. And usually the local health department does the work of these notifications and the treatments, and the STD clinics and local health departments are they're by law, they have to be there. They have to every county in North Carolina has to have an STD clinic available to its residents in the county, and and those STD nurses work very hard to diagnose symptoms of patients and contact the people who the patients have been in contact with, and everyone has to be treated and notified and then treated. Some nursing diagnoses for patients with sexually transmitted disease include acute pain, also risk for infection, transmission to others, ineffective sexuality pattern, fear, help-seeking behaviors. And some of this patient teaching includes safer sex practices, and there is no such thing as safe sex. You have to, you never do know who your partner has been with completely, but we hope that, within relationships that there are such things as monogamous relationships, and we hope that there are things that such things as trust in relationships, and so we have to base our actions on those concepts. But if you do have a patient with a sexually transmitted disease that needs medication administration, then we have to follow through with that, and we have to teach the patient that they have to take all of their medication and they cannot stop. And then we have to look for signs of complications to report as nurses. And if you end up being a public health nurse, then you will be you'll be seeing these conditions, and you will be making certain that outbreaks do not happen in the community through treatment and notification of all partners that have been exposed, so that the spread of these diseases won't continue. Which STD can be cured? Is it venereal warts, AIDS, herpes, or chlamydia? And the correct answer is chlamydia. Chlamydia can be treated with an antibiotic. And what should be included in teaching a client with human papillomavirus or HPV that resulted in genital warts? And would it be the importance of avoiding acidic foods? Would it be measures to relieve the pain, or how to take Aclivor, or the importance of regular Pap testing? And the answer is the importance of Pap testing. And the rationale is that HPV can lead to cervical cancer, and early detection is done via Pap testing. Here you have your answer, the importance of regular Pap testing. What is the nurse's primary role relating to sexually transmitted diseases, or STDs? Is it reporting cases of STDs, sexual counseling, diagnosis and treatment, or recognizing symptoms and education? And the correct answer is recognizing symptoms and education. And the rationale is that the nurse's role is early detection of symptoms and education on prevention and treatment. Which assessment finding indicates to the nurse that a client with a history of gonorrhea is experiencing a complication of the disease? Is it A, frothy gray vaginal discharge, B, inability to conceive, C, vascular lesions of the perineum, or D, condylomata acuminata? And the correct answer is inability to conceive. And what education should be given to the pregnant client who has been prescribed metronidazole to treat bacterial vaginosis, or BV? The woman must advise her partner to seek treatment immediately. B, a repeat culture should be taken 2 weeks after completing the medication. C, the medication can cause severe nausea and vomiting. Or D, the woman must observe for signs of preterm labor. And the correct answer is D, the woman must observe for signs of preterm labor. The rationale is that Flagyl can cause preterm labor in pregnant clients.